So let's look at the preferred method of mobilizing a flap for an extraction of a premolar. If I could choose how I want to create this flap, I want to create it so it makes it such that I've got the least amount of work to do when I'm closing it. But I still get enough access to remove bone without tearing the tissue up. So when we're making our approach initially, what we're going to try to do is an envelope flap. And an envelope flap is just as it sounds. An envelope flap is where we're literally, like we open an envelope and we're looking down inside of that envelope at the bone that covers the tooth root. So in order to get enough mobility to extract this fourth premolar, if I were going to extract that tooth, what I'm going to do is I'm going to start an incision somewhere around here in the sulcus, where my scalpel's straight up and down, and I'm placing that 15 blade down into the sulcus to the bone. Now, you have to be careful when you're doing that. When I say straight up and down, I don't mean literally 90 degrees from the palatal mucosa. I mean straight up and down and angling a little bit toward the bone and not down into the tissue, because if we put this straight down in, there's a good chance that we're going to go straight through the gingiva. So you want to angle it toward the root tip so that you make sure that you're hitting that bone and not going through the tissue. It's very easy to do that. It's not, you'll never run into problems if you remember. You just need to angle it down like you're trying to hit the base of the tooth and the bone interface. And you can look at a skull if you have questions about how that interacts, because it will gradually come off at the cemento-enamel junction at the marginal bone level. It will gradually come off, but it gets thicker as you go down toward the central part of the mandible. So you just want to make sure that you recognize that, and you're not placing that scalpel at straight down where it's going to come through the tissue. That being said, we start in the sulcus, we go up here into where the papilla is, maintaining that papilla. So we kind of make a little divergence here and then come back this way in the sulcus, back up here, back down there, and then down to about that region. And then what I would generally recommend is just take your scalpel and kind of walk that gingiva off the edge of the bone to start with, before we start with the periosteal elevator. You've got a lot of control with that scalpel, and you're maybe getting a millimeter, if that, maybe a half a millimeter head start, so that when you put that thicker periosteal elevator in there, it's not as likely to tear through the tissue. You've got a little bit of a head start against all of this, so you've already elevated maybe up to a millimeter or so away from the bone. Then once you do that, you can take your periosteal elevator, go down below this mucogingival line, and then all of this tissue is not firmly attached, and you can feel that luxator, or that periosteal elevator, as it breaks that chasm between the attached gingiva and the unattached gingiva, and it will be much easier. You can feel that when it just kind of breaks through that attached gingiva, and then you can get a little bit more aggressive with it. So what we're essentially doing is creating a little window where we're dropping that gingiva down maybe about that far, so that we can get our burr beyond that to remove the vestibular bone and create some little grooves here. The depth at which you want to go depends on what the tooth looks like radiographically in general. Now, if I take an x-ray of this and I see that there's ankylosis and there's tooth resorption, I'm either going to do a mesial or a distal envelope, or a vertical releasing incision in order to get access and not even try to do an envelope flap, because I know I'm going to have to go deep apically to remove bone to even think about getting that root out. So this would be ideal, but you're not always going to be able to do that based on what you see radiographically. If it's a young cat and this is a fractured tooth, or it's an early tooth resorption and you've got a nice periodontal ligament space, there's going to be a good chance that you're going to be able to remove that without having to get all the way to the apex. But not always. Sometimes you'll still have problems. Sometimes you'll fracture a root trying to do an envelope, and then you'll have to do a vertical releasing incision. So let's say we attempt to do an envelope flap on this fourth premolar and we don't succeed. We end up fracturing this mesial root here. We get the distal root out okay, but the mesial root we fracture, and we've still got about a millimeter and a half of root tip there at the apex. What I'm going to do is I'm going to start on this line angle right adjacent to this tooth, on the tooth next to it, on the third premolar, and I'm just going to diverge an incision down about that far. And what that's going to do, it's going to allow me to open all this up so that I can safely use my periosteal elevator to retract that tissue apically and paint away all of the bone all the way to the root tip. And that way I can remove the root tip. So ideally, use an envelope, but you can't always do that. Now, if we're looking to extract this whole quadrant, if all of these are affected with periodontal disease plus or minus tooth resorption, then what we're going to do is we're just going to come up here and make an incision all the way down like this. And we don't even have to worry about these papilla. We can just take and do a straight, nice incision all the way down, all the way up here, so that when we go to close, we've got a nice line. We don't have any fimbriation on the margin of that tissue. We can just close it directly with the lingual mucosa. And we don't have to worry about getting far enough down because we're going to be exposing all the way to the apex when we do that. Very easy to get exposure that way. With the maxillary teeth, we always do a vertical releasing incision for the fourth premolar and for the maxillary canine tooth. The vertical releasing incision for this tooth would be up here, and then we'd carry this incision back to this area. It's easier for these premolars versus the mandible to do envelope flaps because there's not a lot of thick cortical bone around those roots. It's more of a cancellous bone. So this is a much easier extraction than would be the fourth premolar in the mandible. So almost always with this tooth we can do an envelope flap, and it doesn't even have to be that big of an envelope flap. All we want is enough to section that tooth without grabbing that gingiva. So we really just kind of lift it off and away so that we can use our periosteal elevator to keep it retracted while we take our crosscut burr and go and section this tooth. And we'll show exactly how to extract this tooth in a little video shortly. One piece of anatomy that you need to realize when we're doing extractions is on this fourth premolar, on the distal root, there's a piece of fibrous ligament that attaches to the bone right next to the distal root on that fourth premolar. So many times that bone starts to get thicker right there at the apical 2/3 of that tooth root, and consequently what you can do instead of macerating this is you can take your burr and go up underneath and create a ledge of bone, still see that distal root, and then work up under that ledge to put your groove in the mesial and distal aspect around the root so that you can get your luxator in and get that out of there. If you have to, sometimes you need to either elevate that and excise it, or just use your burr to cut through it in order to get access to that distal root. But you'll encounter that. Here's that little maxillary molar. This is the left maxilla. The patient's, here's the palate, so we're facing it apically. Here's the cusp of the teeth. And so with this tooth, when we're extracting this, this is one of those simple extractions where all we do is place our luxator in here, and we can actually use it kind of against that tooth to lever it out of its alveolus. Very simple to get this tooth out most of the time. And you can see this on radiographs where you see a periodontal ligament space that's enlarged. You can also use your probe, your periodontal probe, to try to manipulate it to see if it's mobile. If it's mobile at all, it should be extracted.